without much ado, I would like Dr. Pooja to please go ahead with her presentation.
Thank you, ma'am. So I'm going to be talking about a topic which is relatively new, but of course it's the future, and you will all see in your clinics in probably next 5 years. So we do have topography, biomechanics, and OCT-based indices to differentiate the normal cornea from the suspect keratoconic cornea. But still, we do come across some scenarios where we are not able to judge whether it's absolutely normal or absolutely abnormal. Like few cases my previous speakers have already shown. So what is happening here? Let's see this example. Looks suspicious topography, but the indices are completely normal. Extremely normal looking topography, but bad D and TBI is suspicious. So why are the structures and biomechanics not matching? When we went ahead and did a surgery when the indices were normal, this patient landed up into ectasia, but the second patient where the indices were abnormal, the post-operative outcome was extremely normal. So why is this happening? Why is the ectasia driven by unknown factors? Collagen fibrils provides a biomechanical strength and the shape to the cornea. But there is no current way right now to study except excising the corneal tissue and doing a gene expression analysis. But that's not feasible for all patients. So what do we do? Is there a non-invasive way to study the collagen fibril orientation and distribution? We came across this principle of polarization-sensitive OCT, where the polarized light is thrown on the cornea. All the structures of the cornea takes up the polarized light and gets bifringent, but not the stroma. So we took the advantage of this property, and this helped, we built our own polarization-sensitive OCT in collaboration with University of Vienna. This is how it looks, but in future it will definitely look like one of your OCT in your clinic. It does have added advantages in comparison to the currently available high-definition OCTs in terms of pixels, depth resolution, and the frequency as well. I'm not going to bore you with the specifications, but it is superior to others which are available. It gives us information from the epithelial thickness without extrapolating. The epithelial thickness comes in a zone of 11 millimeters. It does give you the Bowman's thickness, the first ever tool to quantify the Bowman's layer thickness. If it's a thin, you have to be very much careful because it will, if you do a surgery on this patient, post-surgery, it will be unable to maintain the integrity of the eye, and this might land up into ectasia. But if it's a normal or a thicker Bowman's membrane, you can close your eyes and go ahead with the surgery. So this is how your collagen orientation looks like. This is the theoretical representation of the right and the left eye. Just to make it simpler, this is the pictorial representation. It's just like your topography colors. The darker or denser the blue, that means the collagen orientation and the density is tighter there. But the more it goes towards light blue or green or yellow, that means the collagen is not present or loosely attached there. This is how a normal case looks like. In a form-thrust keratoconus, there is a partial loss of orientation and arrangement of the collagen. And this is a keratoconic eye where there is complete loss of orientation and arrangement of the collagen. So this is how the collagen fibers will look like. So let's take these two examples. Bad D and TBI is suspicious. Here everything is normal looking topography, suspicious looking topography. But the Bowman's layer is extremely healthy here, and here it's on the thinner side. And if we do a collagen orientation, there is, even if it's normal looking with normal indices, there is a complete loss of orientation and arrangement of the collagen. But here in the suspicious looking topography, it's absolutely normal. So if we do a surgery, this patient might land up into favorable outcomes, but this will definitely lead into a unfavorable outcome. This is another case example, a normal looking topography, a very good CCT of 546. But if you see, we do not have an answer to this yet, but if you see the collagen is completely absent, and of course this is not a case where we would like to do a laser-based cornea surgery because there is always a fear to land up into ectasia. So we've just devised a simple nomogram. If everything is healthy, then we can go ahead and do a refractive surgery according to the surgeon's preference. But if the Bowman's membrane is thin, you do a smile extra or phakic IOL. If the collagen orientation is poor but a thick Bowman's membrane, again a PRK extra or phakic IOL. But if it's extremely abnormal, then you do a phakic IOL. Thank you.
Very interesting, and you've evolved this thing so far. It's come out really good and looks really exciting. And I'm sure that once this can reach the hands of more surgeons, everybody is going to really enjoy it. So is there a chance that this will become commercially available
Absolutely. Since past 6 months, we are almost now collaborated with one of the leading topographer company, which is global, and they are very much interested to make it commercialized. So
Great.
maybe in
So
next 6 months.
Great,
Are there
great.
any shortcomings to this? Is the reproducibility, the sensitivity,
Ma'am, we've done a repeatability study and it's quite repeatable, so it shouldn't be a problem. And what we have done is we have correlated it with molecular markers also. So what we are seeing on pictures, is it really matching on the tissues? We have done that and it's quite
and what
comparable.
about the sensitivity and specificity?
It has a 98% sensitivity specificity. That's already published, ma'am.
So it looks like this is going to be the future in investigation.
Hopefully.
Thank you so much. It was
Thank
a
you, ma'am.
wonderful
Thank you.
presentation.
Thank you all. Thank you for giving